First of all, I am very happy to see that you're all here, at least those who promised to come had made it safely to Morocco. And we welcome to the 5th edition of the Scientific Days of the Association of the Southern Urologists. This year it will include especially a workshop on PCNL and RARS, conjointly organized with Moroccan Urological Association and the International Alliance for Urolithiasis, IEU. This event would have never been, or would never have seen the day without the diligent work of our members over the last 6 months, and the active collaboration of the Moroccan Association of Urology and the IEU. The help we get from the authorities, and we are especially grateful to the Foreign Affairs and the ambassadors of His Majesty who speeded the process of granting visa to our guests. A special thanks to the sponsors who believed in us and what we are undertaking in the era of big squeeze. This year, we have an exceptional panel of experts. Introducing each one of them is tantamount of reading an encyclopedia. So I was left with the task of either going too much in details or skipping over crucial part of their outstanding achievements. So for the sake of simplification, I will briefly introduce them, and I will start with 3 absentees. Unfortunately, Dr. Kemal Sarika could not join for some special reasons. Professor Mohammed Lazraq, who is recovering, unfortunately he was sick over the last days, but he's now recovering. Professor Gohuazang, who will be with us live from China in maybe a half hour, and he will do 2 lectures and perform semi-live surgeries. And present with us, we have Dr. Iski Paul and Dr. Vadi Chandra Mohan from India, Dr. Sanjay Kadge from Nepal, Dr. Mehmet Gochi from Turkey, and Professor Sven Lam from Germany. It's good to get you all here after a long period of time of imposed separation. Our aim is not to organize sporadic events, but to capitalize on this kind of events as a springboard for the future, to create bonds between our society and associations, to exchange experience and expertise, to train residents and fellows, to build cooperation program within the framework of the IEU. I will take this opportunity to actively call on my fellows Moroccan and African urologists to join the IEU. And I am sure that any breakthrough to come in the future in urolithiasis research and management, it's going to be through this diligent work and hard work of members of the Dynamic Alliance. Dear fellows, we will have 2 full days workshop, including lecture, live surgery, and semi-live surgery. Transmission live from the International Hospital and semi-live from Guangzhou, China. The program is with each one of you, and will earnestly request from speaker to stick to the allotted time. Welcome all to Agadir, and hope you will enjoy the conference and your stay in this beautiful city. But be relaxed, don't be stressed. What we can do, we'll do. What we cannot do, we'll do without. We will be flexible, so enjoy your time, and we will hope that you will spend a very great time with us this year. And without further delay, I will pass on to Dr. Iski Paul for his presentation on PCNL. So it will be the first one.
Respected senior members in this August gathering, dear friends and colleagues, a very good morning to all of you. At the outset, I am thankful to Dr. Zain Abdul Fadl and other members of Scientific Committee to have given me this opportunity. I bring you greetings from India, and I am working in this hospital, which is 1,700 bedded hospital, and chairman of this hospital, Dr. Pratap C. Reddy, he brought a sea change in the medical treatment facilities in India. We are going to discuss about instrumentation and techniques for renal access. This talk should be given to the youngsters, and it is meant for youngsters, but I see many big doyens of PCNL in this audience, and I will like to get excused, but I will take their guidance if they differ with me, and they will be guiding me what wrong I have gone through. We know in renal access, the most important step is to make a short, segment, straight track. Every word is important. It should be a short and straight access track through a fornix. Straight coming to three techniques of PCNL access. These are bullseye, triangulation technique, and gradual descent technique. I will go through these one by one and explaining why they differ from each other. Our target patient is a patient having a renal stone in the pelvis and he is lying prone, because 80% of the urologists in the world are still doing prone PCNL. So this is our index patient on which I am going to talk about. Now when the patient is lying supine, this is how the kidneys are. They are not vertically or horizontally oriented. They are tilted 30 degrees. And when the same patient gets turned prone, the kidneys are tilted at 30 degree like this. You can see my cursor, okay. And this is our target. This is the posterior calyx. This is the anterior calyx. These are our targets in which we have to make a track. And when you have a target, you should see straight it on face. You should not see it sideways, and therefore you should position the C-arm like this when you are going to make a track with a 30-degree tilt towards you, so the image intensifier is hitting your head. And at the same time, when you position like this and see your target on the face, the X-ray tube is going away from you, so that your fertility remains maintained. So this is the reason, two reasons for which you should position the C-arm like this. Not only that, when you position the C-arm tilted 30 degree, your needle puncture on the renal parenchyma is going to be lateralized. If you position C-arm in 0 degree, you are going to puncture this area. When you are positioning C-arm in 30 degree, you are going to puncture this area. And this 1.5 to 2 centimeter migration of renal puncture makes a lot of difference as far as bleeding is concerned. Why? Because when the renal artery enters into the system, it divides into two branches, anterior and posterior, which further divide and subdivide, make into segmental, then interlobar, intralobar arteries, and ultimately they form a arcuate artery like this. If you are puncturing in this area, which is about 1.5 to 2 centimeter medial to the lateral border, the bleeding is going to more. While if you puncture the convex border of the kidney, the bleeding is going to be less. Therefore, you should always try to make an access through the convex border of the kidney, which is the Brodel's white line. We used to do nephrolithotomy, anatrophic nephrolithotomy through the Brodel's white line, used to bivalve the kidney, take out the staghorn and close it, and bleeding used to be minimum. Now once you have positioned your C-arm in 30 degree, what do you see? One exposure of C-arm is like seeing the word only with one eye, or like taking a picture. Is it enough? Even if I close one of my eye, I can see everybody sitting here. But is it enough for an accurate puncture? No. Because one view of Siam gives you only length and breadth. It does not gives you the depth perception. Let me explain. This is the picture by a camera. You can see the moon sitting in the cart. You can see the moon hanging from the crane. You cannot appreciate the enormous amount of distance between the moon and the cart. This is what you see with camera or with one eye. Now, if God has given me only one eye and I have to see the distance, what I will do? I will move from here to here. I will shift one eye from here to there and then try to see the distance. So what happens when you are seeing only through one side, only with one view, whether the needle tip is on the surface or needle tip is on the target or needle tip is deeper to the target, all these three positions of the needle in Siam, they will look like this. You cannot appreciate whether the needle is at the target or on the skin surface. Therefore, God has given us two eyes. Every object we have to see with two angles. Then only the third dimension and the accuracy of track comes in. Once you have a view in 30 degree, this is the most important slide for the beginners. Please concentrate on that. Once you see the view in 30 degree and the needle is at the skin surface, at the target or deeper to the target, it will be seen like this. Once you turn your Siam from 30 to 0 degree, once you turn your Siam from 30 to 0 degree, now whatever needle tip comes on this line will be seen at the target. And it is only this yellow needle which is seen in 30 degree as well as in 0 degree at the same, it is at the target. While this needle, the red needle which was seen at the target in 30 degree, as soon as you turn from 30 to 0, it moves lateral to the target. It remains lateral to the target. So anything which moves lateral to the target is superficial. It is behind. It is posterior. It is not at the target and vice versa. Am I clear on that part? Now let us see this. When there is a fluoroscopic image with Siam in 30 degree and needle remains here, as soon as you turn from 30 to 0 and the needle tip is seen here, it has moved lateral to the target. It is superficial. So what you have to do? You have to increase your angle and go deeper. This is the other way around. In 30 degree, the needle was seen at the target, but when you turn from 30 to 0, the needle has moved medial to the target. It has already gone too deep. You have to remove the needle, decrease the angle, and then go in again. In this, whether it is 0 degree or 30 degree, the needle tip remains at the target, means you are at the target. Whether you get the water or you don't get the water, you are at the target. This is the video presentation of the same. The needle is being turned from, the Siam is being turned from 30 to 0 and see how the needle is moving. Needle is moving. Come on, my young brides. Needle is moving lateral to the target, so it is superficial. You have to increase the angle. The other way, when the Siam is being turned from 30 to 0 degree, and see what is happening in the image. The needle is going medial to the target. You have gone too deep. Remove your needle, decrease the angle, and then go in again. And in this particular video, when the Siam is being turned from 30 to 0, the needle tip remains there only in the cup of the furnace. You are at the target. Now, if you have understood this much, the understanding techniques of PCNL is very easy. Basically, there are three techniques: bullseye, triangulation, and gradual descent. In bullseye, you can do it any angle. You can position at 0 degree, and wherever you see this calyx, start from there, go deep, 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 maintain your needle tip and your needle hub both in the same straight line, go deep, deep, deep. At one particular time, you will definitely hit the target. You can position the C-arm in 0 degree, 30 degree, 15 degree, any degree which suits you, and you have to just maintain the needle tip, needle hub, everything in the same straight line, go deep, 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 you will hit the target. It is the simplest technique. Needle tips, you have to just, your hands will get exposed because you are coming on the way of this. You see this is, puncture is being made with the bullseye technique. Needle tip, needle hub, everything in the same straight line. But whenever you make a puncture like this, your puncture from the skin up to the needle, up to the target, up to the calyx, this is a vertical segment of your track. And then what you have to do, once you reach, and if the stone is in the pelvis, you have to bend and go inside. And there will be fulcrum effect over here, because your track has two segments. One is a vertical segment, and one is a horizontal segment. So there will be bleeding. And bullseye technique, you will be puncturing this portion of the kidney, medial portion of the kidney. There will be bleeding. So these are the advantages and disadvantages of bullseye technique. It is simplest. You will always be able to puncture the kidney. Just maintain the needle tip, needle hub in the same straight line. Go deep, deep. You will get it. Let us discuss about the second technique, triangulation technique. In triangulation technique, what you have to do, you make a point A on the skin with the C-arm in 0 degree. Mark it. Now turn from 0 to 30 degree, and now you will be seeing your target at point B. Mark it. So this is a AB distance you know on the skin surface. In this bargain, you have made a right angle triangle on the skin. Therefore, it is called triangulation technique. This contour is never straight like this. We assume it is a straight line. So if you assume this, it is a 90 degree angle. And once you have turned the C-arm from 0 to 30 degree, this is the angle which is 30 degree. So if you have little bit of geometrical background, you have made a right angle triangle on the patient's body, where you know that this line AB, you know this is the 90 degree angle, you know this is a 30 degree angle, obviously this will be a 60 degree angle. So you have a 90, 30, 60 degree angle, and you know one of the line. So it is very easy by Pythagoras table, you can calculate that this, if you have the length of AB, AC will be 1.7 times of AB, and BC will be twice AB. So this has given you a calculation, exact calculation. By marking AB and measuring the distance, now what you can do is position the C-arm at 30 degree, start from here and go exactly double the length inside. If this distance was 3 centimeter, you know when you will start from here and follow the bullseye technique, go deep, 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 at 6 centimeters you will hit the target. So triangulation technique is just a mathematical calculation to give you exact depth of the target, but you have to do a bullseye technique puncture. Am I able to explain it properly? Right. So this is a 90, 30, 60 degree right angle triangle. Arm AC will be 1.73 times the arm AB, and arm BC means if you are starting with 30-degree tilt, you will be going deep. It will be twice the length of AB, and you will be able to hit the target. I will recommend gradual descent technique. Listen to me carefully. In gradual descent technique, we always position the Siam in 30 degrees. Always in 30 degrees. It is not done in 0 degree. And if I was going to do a bullseye, I should have started from here. I will not start from here. I will go 3 to 4 centimeter lateral. And from as soon as I position my needle on the skin, it will look like this. It is looking about 3 centimeter away from this. And now I will gradually descend down to the convex border of the kidney, making puncture through the Broddel's white line and enter in alignment with the infundibulum, so that this is a straight track, right from skin up to the renal pelvis, taking into consideration all the anatomical things which I told you. And since it is going through the Broddel's white line, there won't be any bleeding or minimal bleeding. Out of my 10,000 cases, touch wood, there has not been a single incidence of angioembolization so far. God knows when it will take place, but so far I have been lucky. So this is how you follow the gradual descent technique and go in, and there will not be any bleeding. So gradual descent technique, you start 3 to 4 centimeter away, go into the cup of the calyx, enter through the convex border, and these are the advantages. The only disadvantage is, since it is very lateral, it is closer to the colon. And therefore, I have an experience of 6 colonic injuries in my lifetime. So, to nutshell, this is a bullseye in 0 degree. I think now you will be able to appreciate. This is a bullseye in 30 degrees, and this is the gradual descent technique. These are the 3 renal access techniques which are followed worldwide. This is how you make a track. Lastly, instruments of my choice. There are so many guide wires available. All of us are very familiar with these guide wires. They are either in straight tip or J tip. I don't prefer straight tip guide wires, because even when the straight tip Terumo guide wire is used, sometimes it can go outside the system. Because when the patient reaches to us and reaches to the table, he has been having stones since long. He was not getting ready for this surgery, and sometimes the mucosa is inflamed and edematous when he reaches to us, and it can easily be perforated. Or straight tip guide wires can make a submucosal tunnels like this. Therefore, I don't use straight tip guide wires. I always prefer J tip guide wires. J tip guide wires, as soon as they come out of the needle, they take the shape of J. These are angiographic guide wire. They are used inside the vessels. They are most atraumatic guide wires. And once the J comes in, you see any forward movement in the pelvic ileal system is with the J. It is not with the straight tip. So it goes very smoothly inside and coils inside without injuring or perforation. Therefore, I always use J-tip guide wires, and J-tip guide wires are the most economical guide wires, costing only $5 per guide wire in India. So this is the advantage. Regarding dilatation of the track, various dilators are available. We are all familiar with that. But I don't use step or serial dilators. One of the biggest disadvantage of serial dilators is they are not dilating till the end. This much portion of the dilator is small. Not only that, as soon as you make a puncture in the kidney, it starts bleeding. It needs tamponade. And what you do? you remove that dilator. Once you remove that dilator, kidney continues to bleed till the next bigger dilator comes in. Sometimes when you are removing, even the guide wire comes out. So there should be, and they do not dilate till the end. If there is a stone right up to this place, they will dilate only up to here, 30 French dilatation or maximum. If you want to push your dilator inside, it is the kidney which will get injured, not the stone. So you should be able to dilate till the end. Therefore, either use metallic Elkin dilators or Teflon telescopic dilator. They slide one over the other. They don't allow the kidney parenchyma to bleed. They just widen the area till the dilatation you want to achieve. So these are the advantages of telescopic dilator, and Teflon dilators are very cheap. They last for about 500 cases per dilator set, and they are easy to get. They dilate till the end. So this is the dilatation I use for mini PCNL, and this is my set for standard PCNL. Take home message will be pelvic axial access should be through convex border of the kidney. C-arm should initially be positioned with 30 degrees of tilt. Don't boast that you can manage every case with monopolar view of C-arm. Monoplanar view only shows you the length and breadth. It does not show you the depth. So it is not scientifically accurate. You should be able to see in 30 and 0 in any plane you want, but two positions, then only you should be confident that you are inside the system. Gradual descent technique provides an ideal access. J-tip guide wires are most atraumatic, and Teflon telescopic dilators, they reduce your bleeding and make your life easier. All this has been published in this book. I have written a chapter, 56 pages, only on this particular thing. I thank and convey my regards to all of you and invite you to come for PERCON 2023. This is a world's biggest PCNL workshop, which is being held at New Delhi every alternate year, but now we are going to hold it every year because the attendance is more than 700 to 800 delegates from many countries. So all of you are invited to participate in that. Thank you very much for listening to me so patiently. Thank you.
Thank you very much. Will some question for Dr. Eskipol? Any comments?
I'll be happy to have some critical comments to improve myself
Sanjay.
wherever my
Then,
concepts are
No
not
comments.
okay. Or
you have any comments?
May I ask, what about ultrasound-guided puncture? Is it also an option for you?
yes, ultrasound guided puncture is absolutely good. It gives you a three-dimensional view. It also gives you intervening organs which coming on the way. But at the same time, it is only till the puncture. As soon as you want to put the guide wire, the best view is obtained fluoroscopically. The movement of the guide wire in the pelvic axial system is best seen by fluoroscopy, not by ultrasound. Ultrasound gives you a puncture, it gives you a nicely dilated calyx, but guide wire movement will not be appreciated well in ultrasound. Am I right, sir? Do you agree with that? Guide wire is not so well seen.
Thank you, sir, for your presentation. It's very informative, and my question is about how you prevent colon injuries, especially in line and 10 patients.
Sorry, somebody was disturbing me very much. Yeah, please come again. I'm sorry I could not listen to you.
How you prevent colon injuries?
Prevent colonic injuries. Okay.
In line, especially in line and 10 patients.
Excellent question. You have taken the needle puncture the first 1 or 2 centimeter of your needle is going through the skin, through the muscles, through the subcutaneous fat and muscles. You are just aiming towards that. Once 2 centimeter of needle has gone in, just concentrate on the colonic gas shadow. You have to see the movement of the colonic gas shadow. I am going to present, my talk is there on the complications and the catastrophes during PCNL. In that I have shown the video how you should concentrate onto the colon, and if the colon starts moving with your needle or starts getting indented with your needle tip, you are going through the colon. So remove your needle. Don't concentrate only on the calyx when your needle is going through. Concentrate on the colonic gas shadow. And if you have an eye for colonic gas shadow, let me tell you, every case you can see where the colon is. What happens? We are only concentrating onto the calyx at that time. Secondly, in 5th or 6th case, I experienced this problem. When I was going through the colon, there was more resistance than what is usual. And if I leave it in between, there was rebound. This later on, retrospectively, I analyzed that this case, there was a rebound. Colon is a little resilient organ. It will not allow needle to just walk in like going through the butter. It will resist. So you should know if there is a resistance or if there is a rebound, and if the colonic gas shadow is indented, you are probably going through the colon. Remove your needle, go little more medial and make a puncture again. One puncture into the colon also doesn't make a difference. Only puncture, not dilatation of the tract.
Sir, good morning, sir. I am Dr. Chandramohan. Excellent presentation, sir. What are your tips for the middle anterior calyceal stone with narrow infundibulum, which is not freely communicating with the pelvis? Do this bullseye triangulation apply where you have to go through larger parenchymal length? It is not connected well with the pelvis as well as the posterior calyx. It's an angulation. So I mean to ask, classical anterior middle calyx, something like diverticular stone, how do you advise puncture safely?
If you study renal anatomy clearly, in the upper calyx, there are only two main. 98% of the times it is medial and lateral. It is not anterior and posterior. It is only in the middle calyx. 96% of the times there is an anterior calyx and a posterior calyx. In the lower calyx, there are 3 calyces or 2 calyces. If in the lower pole there are 3 calyces, it is only the middle one which is posterior. Both others are anterior. This is the anatomical concepts. Regarding your question, in the middle calyx, where there is a true anterior-posterior position of the calyces, whichever is stone harboring calyx, whether it is anterior or posterior, if the middle calyx has a stone, you should do a stone-guided puncture. Lateral puncture, lateral portion of the stone should be punctured. Now, depending upon what is communication, whether it is a narrow infundibulum or what, if you are sure in 0 degree and 30 degree that your needle tip is touching the stone, whether you get the fluid or you don't get the fluid, you are there. Make a track. Once the track is a little wider, the fluid will automatically start coming. There are 3 positions when there won't be any fluid. If there is a thick pus inside, if there is matrix inside which is not seen in image, if there is a lot of matrix all around the stone, or if you have punctured repeatedly and there are clots in that calyx, then you won't get the fluid. It is only 2 positions of C-arm. If you are at that position, you are in. Don't bother.
Right.
Thank you very much for your wonderful presentation. I have begun with the prone position for this intervention, but I switched to lateral position. And it seems to me like I have added a new difficulty for me because I am still following the kidney
because he goes very far with the respiration. What's your impression on that? Have you any experience of this position first? Are the puncture more difficult in this case, especially in the person who are not fat, who are not overweight?
Specifically, your question is regarding supine versus prone positioning.
Yes.
Supine position has two disadvantages. The track is little longer. And therefore, now Karl Storz company has started making longer nephroscopes, longer sheaths for the supine position. It is quite a recently in last year they have started longer nephroscope for supine position. So believe me, although statistics still show that the length is same, but I don't agree with that. Anatomically also in supine position the track is longer. Track should not be longer. Secondly, the kidney is very mobile. When you are puncturing, kidney has no support. So it starts moving more medially and medially. The kidney is mobile organ. So puncturing and maintaining becomes difficult. Therefore, I do supine or lateral PCNL only in those cases who are very badly kyphoscoliotic, who cannot be positioned, or who have COPD, who cannot be done with obstructive pulmonary disease. Very limited cases I will be doing in supine. I am fond of prone and I have never regret that prone has given me anything bad.
Oh, thank you.
Thank you very much,
Thank you very
Professor
much.
Pal. Now we will switch to the second talk by Professor Chandra Mohan about the instrumentation and technique for fragmentation and extraction.